today. Well, I would first of all, on behalf of WAP Respiratory Chapter, would like to welcome Dr. Pawan Kalyan on board. He's the guest speaker, gracing the occasion, who's spending some time with us on a Tuesday evening. For those of us who haven't heard him speak or haven't met him at the recent symposium, let me just very briefly introduce Dr. Pawan. He is the consultant pulmonologist with an interest in allergy as well as a sleep specialist, having done his fellowship in pediatric pulmonology and sleep medicine, as well as allergy and clinical immunology. He has been the secretary of IAP Andhra Pradesh, the state of Andhra Pradesh, and has been the EB member of Central IAP 2020. Apart from being the EB IAP of Respiratory Chapter 2019-20. So a very warm welcome, Dr. Pawan, and thank you for spending the Tuesday evening with us and gracing this occasion. We also have with us Dr. Shanjukta De. She is the clinical director and heads the Department of Pediatrics at Peerless Hospital with an we were just kind of talking about the amount of work that all of us are there's a deluge of a vast spectrum of pediatric diseases going about, but I would say to that there is always a time to talk about wheezing in under fives, because it's omnipresent. We have a fair share of dengue, malaria, typhoid, and scrub typhus, but we always have the wheezers, and we need to kind of keep revisiting them, revisiting the nomenclature, revisiting their problems, and revisiting them in office practice. And joining us on that score is Dr. Amita Sinha Mondal. We've met her on every Tuesday trivia every month. A very active member, and she holds quite a lot of portfolios. Apart from the respiratory bit, she has, she is the kind of trainer in various modules of the Central IAP. She is also a current EB member of West Bengal Academy of Pediatrics, and she's a consultant at Divine Hospital. So I would now kind of hand over the microphone to Dr. Shantanu Bhakto to start the session and moderate the session on wheezing in under fives. Over to Shantanu, please.
Thank you, Devjani. It's a good introduction. In another 40 to 45 minutes, I'll be discussing along with my co-panelists under five wheezers. When I start this program, you'll find it is very, very easy. But as Devjani was telling, it is omnipresent. We always get wheezers, and September, October is the month of wheezing. And we will find, at least I myself find it very, very difficult sometimes to diagnose actually what is the cause of under five wheezing. Anyway, so the first thing, what is wheeze? You all know, it is a musical continuous sound originating from the oscillation of a narrowed air tube, and it may be monophonic, it may be polyphonic. Monophonic when it occurs in trachea, in larger airways like tracheomalacia, bronchomalacia, and polyphonic when there are several levels of obstruction as in asthma. Infants often wheeze more than older children and adults because of their more compliant air tube, and it is often we get the tone of the smooth muscles are increased. Under five children are having peripheral airway tubes which contribute around 50% of more total airway resistance. And so if there is a marginal narrowing, it increases the resistance. And because resistance is inversely proportional to the fourth power of the radius, so it causes wheeze more often. So it is a high pitched musical sound, and all the causes of airway narrowing. And the important thing is you have to validate whether it is wheezing at all. Like temperature, no, people come to you with a complaint of fever and you have to record the temperature. Like that, you have to validate whether it's actually wheezing or not. Wheezing under 50% children wheeze once before 5 years, 30% children wheeze before 3 years. We all know all these things. But the important thing is understanding the cause of wheezing is very, very important. And the more younger the age, more chance of diagnosis other than asthma. As you all know, there are many causes of wheeze under 5 years of age. Taking all these wheezing causes, it may present under 5, it may present as either first time wheezer or the recurrent wheezer or the atypical wheeze. Now in the coming slides, we will have the case discussion and we'll try to decode this wheezing mystery in under 5. Let's take a case. Case 1. Kamalesh, a 7-month-old boy, present with cough, cold, fever for 2 days, irritable, crying, restless, breathing rapidly, feeding difficulty, no similar episode in the past, no family history of atopy, asthma or allergy. On examination, 7 kg weight, temperature 100.4, bilateral wheeze, others are normal. So maybe Amita, you can take up the case. What will be your approach?
So this is a case of a 7-month-old boy, and since the child has cough with cold also, so the cause is viral, and most likely it is a case of bronchiolitis because it's the first time attack, and uh, then because he has no family history, no previous episodes, so we would treat it, manage it as a case of bronchiolitis. We would give a trial of like keep the child hydrated properly, and if oxygen is required, we give the child oxygen, and can give a trial of beta beta 2
So,
agonists. Yeah.
yeah. So we often get such type of cases which end up with bronchiolitis. So we can say that Kamalesh is a first time wheezer. Second case, Sachin is a 9-month-old boy, came with cold, cough and wheezing. Same symptoms twice in last 4 months. Fever was present initially, low grade in 2 episodes, not sick looking. Sangyukta, can you have?
Thank you, Shantanu. I would like to ask the parents some of questions like how did the cough start? Was it a sudden, acute, or a subacute way? What type of cough it is? The timing of the cough, is it daytime more or nocturnal? Frequency of the cough, whether there is, it's occurring all through the day, whether there is spasmodic bouts of coughing, whether there is any audible wheeze. What are the triggers the parents think? Is it the weather, the viral? Is it smoke? Is it activity or exercise? How long it takes to settle? And is there any other symptoms present? And in between, they said you said that he had the same symptoms twice in the last 4 weeks. So in between the symptoms, was the child completely well? And is there any family history of similar problems in the parents, or any family history of atopy or allergy? That's what I would like to ask first before proceeding.
Exactly. Fantastic. So this is a set of questions which the answer of these questions will guide you. Like first 5 points you are related to cough, onset, time, timing, frequency, and duration. Then trigger induced or not. Then internal symptoms is the third point, and personal atopy or family history of asthma or atopy is the fourth point, and lastly response to bronchodilator.
Yeah, response.
Answers to these questions will help us decide the diagnosis and the probability of asthma. Mainly wheezing under 5, we have to find out whether this will transform into asthma later period or not. Otherwise, we have to find out whether it is an atypical wheeze. Now, analyzing these questions in case 2, we find that Sachin has coughed during day and night. Episode lasts for 5 or 6 days. No specific trigger detected except URTI, upper respiratory tract infection. He is normal in between each episode, growing normally, no allergic markers and no families. So, Shangjupta?
So, the thing is that Sachin, I would say that if these are the cases, then Sachin has a viral associated wheeze. So he would have, this is triggered by the viruses because there is no contributory family history. There is no specific trigger, and he's well in between each episode. So I would consider it to be a viral associated wheeze.
Viral associated with. So in GINA 2021, they have come out with 3 boxes of the probability of asthma. And this Sachin at this stage seems to be in box 1. That is, the symptoms of cough, wheeze, breathlessness are there. It is lasting less than 10 days, 3 or 4 days. There are 2 to 3 episodes and no symptoms in between. Interval symptoms are normal. Among these cases, like Sachin, they are having few of them may have asthma. So they fall in the first box. Now, case 2 continued. Sachin visited 2 months later again. This time it was a prolonged episode, continued for 2 weeks, so more than 10 days. He also had 1 episode of wheezing last month that was treated with SABA, short-acting beta-2 agonist, elsewhere. Interval periods, child is not totally asymptomatic, has cough and wheeze off and on. So now, Shangjupta, what will be your approach?
So basically, I will revisit the history again and, ask those 10 questions related to cough history again and find out whether or not, things have changed for Sachin. So he has, as you have said, that he is not symptom free, interval periods are not symptom free. So I would also like to find out whether he wakes up in the night or not, how long he takes to settle down. And we know that he doesn't have a family history of asthma, but he had some response to bronchodilator. So if, as you have said, according to the GINA, he probably will come into the box 2. Now.
Here you often, all of us often confront this question that whether this is asthma, whether this will continue. So what will be your prediction like? As you told, according to GINA 2021, it comes to the middle box where there are symptoms, more than 3 episodes in a year, and night worsening is there, and interval symptoms are also there. So some of them will
have asthma.
Right. Now, case 3, 4-year-old Shubhra, history of cough, wheezing, breathlessness, 4 episodes in the past 4 months. Only 1 episode was associated with fever, has visited 2 pediatricians till now. Now, this is a critical case and goes to Pawan. And what will be your answer like? Pawan, please.
So thank you very much for the invitation. Now, these are the typical cases where we get, the pulmonologist get a referral. So history of cough, wheezing, breathlessness. Here I would like to emphasize again that again with the 10 questions, the most important is it a polyphonic wheezing or a monophonic wheezing? Because this is where people will be tended to give all types of inhalation therapy and the child would not respond and get worsened. So, because as you said, polyphonic wheezing is seen in tracheomalacia, because we do have such cases. The only other history which we should ask is whether the term or a preterm child has been intubated or ventilated. Such questions are also needed for such. So instead of jumping and adding on to the treatment like Deriflin, which shouldn't be given, and Deflazacort given OCS, so this is what we look into. And once you have asked and all the 10 questions what we have, and you said there is a nocturnal cough and wheezing and symptoms are associated with lasting for more than 10 days, atopic dermatitis present, father had history of suggestive allergic rhinitis, triggers of history of cough after running and laughing, that so avoids running and activity. This fits into the box number 3, where you know that their history is more than 10 days and family history of atopic dermatitis allergic markers are present. So these children most have asthma.
Most have asthma. Very right. So, do we need any tests, investigation, Pawan, in
Uh,
cases?
Actually, if the child is not responding to the way I do, because I'm a pulmonologist, because if general pediatrician, after doing, I would generally not do a chest X-ray or an. Sometimes we have to do an absolute eosinophil count to protect, and because the other thing is FOT has come up, that we can try. And lastly, if that is not responding, I would go and look for a bronchoscopy to see whether there's a tracheomalacia or a bronchomalacia.
Very.
Otherwise,
Otherwise, in general, you can do
generally we do.
CBC, yeah, X-ray chest to rule out alternative causes, spirometry if the child is able to do so, allergy tests in case of recurrent or non-responsive wheeze,
Sir,
FEN and impulse.
one emergency has
Yeah.
come, sir. I'll just join in 2 minutes, sir. One emergency.
Okay. Carry on. So FENO and impulse oscillometry are still in their neonatal stage here, and so investigation as such is not that necessary. It is a clinical diagnosis, but if you want to do it in non-responsive cases, you can do so. So this is one more predictor, modified asthma predictive index, where there is more than 4 wheezing episodes in a year. And if you have one major criteria or at least 2 minor criteria, you can say that this child may turn into asthma. Major criteria are physician diagnosed atopic dermatitis, physician diagnosed parenteral asthma, allergic sensitization to at least one aeroallergen, and minor criteria are wheezing unrelated to cold, eosinophils more than equal to 4% in circulation, and allergic sensitization to milk, egg, or peanuts. These modified as
Shantanu, just one question, if I may ask.
yeah.
Yeah, just wanted to ask whether this allergic sensitization has to be proven by an allergy test or it is just a
Yes.
clinical diagnosis.
If you get the diagnosis like egg allergy or prawn allergy, so
Okay.
if you get all these things, okay.
Then it is.
Otherwise, you have to, yeah. So these modified asthma predictive index are having a moderate positive predictive value. If they are there, might be asthma, but if they are not there, yeah, it is having a good negative predictive value. That means it is not going to be a asthma. So the current understanding in under 5 wheezing is treatment is guided by the frequency, duration, and severity of the symptoms, that is night worsening or not. Interval symptoms, whether child is free of symptoms or having symptoms, personal and or family history of allergic conditions are there or not. Asthma more likely in under 5 wheezer if duration lasts more than 10 days, child symptomatic in between episodes, activity induced symptoms, nocturnal aggravations are there, personal history of atopy or family history of asthma is there. So this is what we are having about wheezing under 5. Now, all that wheeze is not asthma. As you all know, we have told that there are many causes of wheeze under 5, and these are atypical wheeze where there are other causes than asthma, and they may be serious underlying disorder, and they are called asthma mimickers. But when to suspect? Again, we'll take some cases. So you have to rule out mimics always. Before you start treating these patients, you have to rule out mimics. A 5-month-old baby presented with recurrent wheezing whose history dates back in her neonatal period. Further, she is having history of poor feeding with choking episodes and a stridor started with within few days of birth. So Amita, can you predict this case? What would be?
Child less than 6 months, we should be more alert and not label it as wheeze, and we should search for other causes of wheezing rather than only viral. So this seems to be a case of gastroesophageal reflux because the child is having frequent choking episodes started right after birth, and a milk scan would probably help to diagnose.
And they are having barium esophagus also, which is saying, though it is not very confirmatory, and child is better, baby is better when is in proper position. The
Upright,
case
yeah.
of GER, which may be the case in 21% of cases due to chronic cough and wheezing.
Sir, once go
Yeah,
back
yeah,
a
yeah.
slide.
Yeah, yeah.
Go back one more slide. You have also misleaded us with one point, sir. Why there is a strider?
Ah, why there?
So,
Yes. Tell
so
me.
when you
He has
see such thing,
added laryngomalacia also, yeah.
correct. So that is what we need to, because people will think of when you see such a strider and when the child tries to be on a lateral side, the strider reduces, and with each and every episodes of the URI, the strider increases. So people start keeping panicking because of the retractions what they see. So when you see such strider cases with laryngomalacia would be associated with GR. If the child is not what you call thriving well, then only we would intervene. Otherwise, we just tell them wait for 2 years. The peaks at
Yes.
9 months and again regresses. So laryngomalacia is an associated GR. So be careful when you see such associations. We need to start anti-reflux medications when you see such cases.
Of failure to thrive. So strider, the baby is better in prone position or in lateral position, right?
Correct, sir.
Okay. So next case, 4-month-old baby presented with cough and wheeze associated fever, tachypnea, nasal flaring, feeding difficulty. There is no family or personal history of atopy. This is the X-ray, Sanjukta.
So there is tachypnea, nasal flaring, feeding difficulty. Now, feeding difficulty, I would like to also ask, is the child, while feeding, does the child start sweating?
No.
That is very important because, one of the commonest, less than 6 months, we always need to rule out congenital disorders, as Dr. Pawan has said, and also congenital heart disease as well.
Right.
Because I've personally been associated with a case in England where the GP was sued for millions of pounds simply because he could not diagnose a congenital heart disease and kept on, treating the child with inhalers. So, when you are saying feeding difficulty, I would like to ask whether the child sweats during the feeding, and if there is wheeze also, is there a hepatomegaly or not? Is there a cardiomegaly, even borderline cardiomegaly? And is there any murmur? So these are the things I would like to find out, and whether the child responds to salbutamol or not.
Okay, principally you want to differentiate it from congenital heart disease.
Yes, very important.
Yes. So this X-ray with hyperinflation on both sides, with tachypnea, nasal flaring, and all these things, it seems like it's a viral infection like bronchiolitis, is a straightforward case like. Okay, Sanjukta, are you happy with this?
Okay.
Okay. So the next case,
Sir.
yes.
Because you said the feeding difficulty. What is the feeding difficulty? Each time when I feed, I am choking. Then
No.
I should also, that is one place where we should also think of tracheoesophageal fistula, where I have diagnosed at 11 years of age having recurrent cough and wheezing at that time. So they missed at the prime period, and the child was presented having recurrent cold cough, and I did at 11 years a bronchoscope and identified a H type of tracheoesophageal fistula.
It's very difficult. Yes, Dr. Pawan, this can be very misleading. The H type of fistula can remain undiagnosed for years.
Correct. So that is the reason when you see and having a halitosis type breathing, and mother typically gives, my child is having some choking like episodes, then think again, because these are the asthma mimickers which you need to think at this age when they have repeated episodes.
So feeding difficulty without any choking episodes may be due to tachypnea only.
Yes, sir. Yes, sir, Shantanu, absolutely. Okay. But whenever you say feeding difficulty, our antenna goes up. Like, what is this feeding difficulty?
Yeah, right. Thank you.
More detailed history, sir. That's nothing more.
Okay. So the next case is 6-month-old male was brought with history of cold and cough with low-grade fever, followed by wheeze and breathlessness after 2 days. Treated as viral bronchiolitis like previous case, admitted for 2 days and settled and discharged. No follow-up for next 3 months. Brought again after 3 months with history of cough and breathlessness. Since 1 month, no fever, not feeding well. On examination, heart rate 148 per minute, respiratory rate 56 per minute, bilateral wheeze, subcostal, intercostal retraction, no murmur, liver 3 centimeters soft. Weight gain only 800 grams since last visit, poor response to inhaled salvage, and also received oral prednisolone, no relief. Now, Pawan, it's your case.
It's my case, sir. Okay, okay. So why is the child coming again and again? Now he has a subcostal intercostal retraction and there is a liver of 3 centimeters and not gaining weight. Previously, madam has asked whether there's any sweating on the forehead. Now, because you haven't mentioned that, why could this could not be what you call a congenital heart disease at this point when the child is not responding, having because of such tachycardia, means not that tachycardia, we could appreciate a murmur, but definitely liver 3 centimeters, 1 to 2 centimeters acceptable, 3 centimeters just I'm little worried. So you have done
Cardiomegaly is there.
so
This is the X-ray.
so X-ray is clinching the diagnosis with you 2D echo is the only thing. So X-ray cardiomegaly with increased pulmonary blood flow is definitely indicative that this could be a congenital heart disease.
Why there is no murmur, Pawan?
Large
Sir.
VST, there will be no murmur.
Correct.
Large
Sometimes there is the
VST, no
flow.
murmur, or the child is very irritable,
Correct.
not find out. This may be another case, another cause. So,
Shantanu, can I just say one thing here?
yes,
Because
correct.
I feel this case personally. I remember this was a similar case I saw when I was just a registrar. Started off in UK, and my consultant was from India. And when I went and told him, sir, I feel this could be a VSD, poor feeding. The GP has referred. Weight has fallen from 95th centile to 15th centile. And this has happened. And I feel the apex is in the left, anterior axillary line, but the murmur is very soft. He told me one thing, this is not India. He told me, we diagnose VSDs in utero. You have come आप इंडिया से अभी आए हो तो आप सोच रहे हो कि ये VSD है, this is something else. We diagnose VSDs in utero in England, and that patient turned out to be having a VSD, and the GP got sued for £1 million.
Oh.
So this is bringing back that memory that how, and he being an Indian consultant actually told me, आप इंडिया से हो,
in a British way,
Yeah.
British way, yeah. So, if the onset is below 6 months of age, specifically aspiration syndrome, consider aspiration syndrome like G reflux, then bronchiolitis and congenital heart disease. These are very common. So again, rule out mimics. Next case, 2-year-old child presented with recurrent wheezing since last 1 year. On auscultation, decreased air entry on left side of the chest. X-ray shows unilateral emphysema. Your thought, Amita? This is inspiratory film, and this is expiratory film.
Apart from hypopnea, so this is showing a left-sided emphysematous changes, and maybe it is a foreign body which you should think of a foreign body which is leading to such changes. But the inspiratory film is not giving any.
Inspiratory film doesn't look like so, because when you take the inspiration, both the lungs around that foreign body, the air passes in, but during expiration, it acts like a valve and there is a air trapping. So that's the reason why inspiratory film.
Yes.
Right. So when there is a localizing sign, you have to find out whether it is a foreign body case or not. Next case.
Sir. I will add. Sir, do remember that you have only sent a foreign body of left localizing. So it could be still a migratory foreign body which can be coming from this side to that side, or you can have two foreign bodies which recently one of my colleague has found two peanuts on two different sides. So you don't know what is happening. So recently there was a child who is an 11-month-old child who had a wheezer, and mother also has given a history of choking while eating peanut. They have given nebulization and everything got settled. But in spite, the mother has given a history that the child had peanut choke. Yeah. So we did a check bronchoscopy because the consultant said, why should we take a risk? And when we did, and we did find a peanut. So you need to have a lending ear to the mother when they say, even though the child responded, there was no decreased differential air entry, which we generally see. So that is one thing. And second thing, when you heard of differential air entry, we generally think of foreign body. Sometimes a mucus plugging can also cause such things, and we need to. So that these are certain things.
Is very important.
Yeah.
So your consultant is not like Sanjukta's consultant.
Absolutely.
Thank you.
And that is event nearly 20 years back, but you never forget such events.
Yes. So 9-month-old male comes to the ED with a chief complaint of wheezing and coughing for 1 day. He has no fever, vomiting or diarrhea, no history of foreign body aspiration, no family history of asthma or atopy, no history of feeding difficulty. Patient has had history of recurrent wheezing since 6 months of her age. So 9-month-old male, chief complaint of wheezing and coughing for 1 day and recurrence from 6 months of age. On examination, temperature is 99, pulse is 120 per minute, respiratory rate is 60 per minute, O2 saturation is 87 room air. He is noted to be in respiratory distress with audible wheezes. He is given salbutamol nebulizer with marked improvement in symptoms. On follow-up after 7 days, child still wheezing and tachypnic, intercostal retraction. His ICS started and bronchodilator continued. 1 month follow-up revealed persistent wheeze with poor response to ICS. And this is the X-ray with left-sided hyperlucency, decreased pulmonary vasculature. Sanjukta?
Could it be, there's no pulmonary vasculature, pulmonary markings over there at all, isn't it? So the child is not responding to nebulizer. Oh no, he is responding to nebulizer, but he's always, and he's quite tachypnic. His saturations is also less. So we have to think of some mass effect on the on the airways to the left lung, because I saw a similar case and it turned out to be a mediastinal lipoblastoma. But in that case, the child did not have any wheeze. The child only had tachypnea, tachycardia, and less oxygen saturations. But if there is a wheeze, then it will be pressing on the airways, so that there is a airway effect. There should be. So we should do a lateral X-ray immediately. If nothing else, a lateral X-ray should be done.
Okay. Pawan?
Sir, I just wanted to some more. Temperature was there, respiratory rate of 60, saturation of 87% room air. Why should there have hypoxemia at this stage? 1 point. And he's noted to have respiratory rate with audible wheezes bilaterally or unilaterally. One thing. And the wheeze, which is what you are hearing, is a monophonic wheeze or a polyphonic wheeze?
Polyphonic.
So if you say there is a mass effect, then you have a monophonic.
Monophonic.
So there you need to, and the child, why was the child sent home? Sir, go back, because here itself only, because if you see, sir, take your pointer to the chest X-ray, and then please show that you are seeing the bifurcation of the trachea, but you are not able to see the left main bronchus. I am only able to see the right main bronchus still here.
Left main bronchus is visible only a little bit, and then it's lost.
That's it. So what?
But Pawan, left main bronchus, is it visible very often?
It would be, sir. If you go back to your X-rays, it would be seen until. But if you see, because you have shown the lateral X-ray, there is some amount of mediastinal widening here itself. In the AP view itself, where we can express that there could be some mass effect which is been going on. But only one thing which I was supposing, the X-ray was done in the initial go, why would the child be sent on 7 days and after 1 month?
Yeah.
That's all. So initially only we should be, because it's a learning lesson for everyone that
the child wanted to, the parents wanted it, they could not afford.
Okay, sir, fine.
The first episode, I think one thing we should always do, the first episode of wheeze, chest X-ray is a must, I think. That
Yes.
was one of the protocols we used to follow in one of the hospitals I worked in. And I think first episode of wheeze, however, barn door wheeze, it seems to be one X-ray is a must, because we have been caught out with something like this. As I said, I found a mediastinal lipoblastoma. And another case, there was no history of foreign body,
Episode
but
of
there was
unilateral wheeze, I think. That should be a unilateral wheeze. If it is a clear-cut wheeze which is coming in the viral season, I don't think so we should go for an X-ray. Because if it is a unilateral wheeze, then I think we should have our antennas up. Otherwise,
first episode of wheeze, I think one X-ray is a
It's not
must, because
recommended.
that was the
Not
protocol. That is a nice guidelines that I remember from years ago.
Even otherwise, when there is a poor response to ICS, when there is a follow-up, the child is still tachypnic, you should go for an X-ray.
Yeah, if he's not
That is all
improving
right. That
with
is okay.
salbutamol and yeah.
And also in the AP view, PA view, if you can't find anything, you can go for lateral X-ray. Here you can find what Pawan was telling or Sangyukta was telling. There is a mass like bending the trachea in forward, right?
Yes, there's narrowing.
Yeah, narrowing at the lower part of the trachea. So these findings are suspicious for a large mediastinal mass which is compressing the lower trachea and mainstem bronchus, causing obstructive emphysema of the left lung and decreased perfusion of this lung. When the obstruction is in the central position, I think wheeze can be hard centrally only. Yeah.
But it would be definitely monophonic wheezing, sir.
Monophonic. Monophonic. Larger airways, monophonic wheezing, most likely. Right.
You wanted to confuse us by telling it's audible wheeze rather than giving a total history, sir. So
it's not revealing it all.
If I say everything, then how the case will continue?
Yes, sir.
So this is one thing. What is your comment? All the panelists. Barium esophagus was done.
So esophagus is compressed. So there is something in front of the esophagus that is compressing it.
Yeah, there is a mass effect. That is
mass effect is there.
Whether barium esophagus was needed or not. That is my question.
Now,
I think
nowadays
go for a CT scan before. CT scan before that.
Right. Pawan, you want to add anything?
No, sir.
Very tricky one?
No.
Okay. So CT scan was done, barium esophagus was there, and you can see the mass here itself. It is very obvious. And CT scan was done. There is a cystic mass posterior through the trachea and mainstem bronchi. Mass causes marked narrowing of the left main bronchus. Esophagus is displaced to the right by the mass with flattening of the esophageal lumen. It was a bronchogenic cyst. So if localizing signs are present with unequal air entry, unilateral emphysema, radiological localization, consider foreign body aspiration, congenital anomalies. So rule out mimics again. 5-year-old child presented with chronic cough with vomiting for last 3 weeks. Cough is spasmodic in nature and associated with low-grade temperature. Pawan, it's very simple.
You said spasmodic cough in nature. So I would definitely think of like illness. So people, basically you need to ask the history. The mother would say the cough. So when you have a spasmodem or paroxysm, you need to ask and the child become reddish. You'd not be having such red eyes. Definitely the child face would also turn red. When you hear such cough, definitely you should think of like cough.
Flushing of the faces. So persistent symptoms of recent onset, if it occurs, you consider pertussis, tuberculosis, adenoiditis, and sinusitis. These are the cases: persistent wet and productive cough, maybe due to protracted bacterial bronchitis, suppurative lung disease or bronchiectasis, cystic fibrosis, or primary ciliary dyskinesia. Have you seen any cases, both Sangyukta, Amita, and Pawan, protracted bacterial bronchitis? How common it is here?
Maybe I could not have diagnosed, but I haven't.
That's the problem. The diagnosing. How do we diagnose this? Unless we do a bronchoscopy, I don't think, or we do a trial of antibiotics. It's very difficult to diagnose, I think.
Right. Okay.
Sir, I lost my current, but I just wanted to add
I
little
think he
points.
can, yeah.
So very commonly we see this protracted bacterial bronchitis. Only thing is that by the time they come, they would have been taken some
Antibiotics.
antibiotics. So if a child is thriving well, if the child is thriving well, having no clubbing, nothing, and having persistent wet cough for more than 3 weeks,
Yeah.
please do suspect your protracted bacterial bronchitis, because it is the one end of spectrum of your chronic suppurative lung disease. If you don't treat, it would turn to bronchiectasis. So it is very, very important that we need to ask, because for each and every cough, somewhere or the other, if your doctor doesn't prescribe, the parents themselves go to a nearest medical shop and get an antibiotic. The other issue is that the color of the sputum, all yellowish color are not always infective. The only thing you should think that there is a shedding of epithelium. Until unless it is greenish color, you need to get worried. Now, the other issues which I wanted to talk about PCD, which we have commonly seen, is that a child who is presenting with chronic wet cough, that is a wheezy type of illness, with having a term gestation, because you should have the history that the child is having wet cough. Because I had a patient who I've seen been treated like an asthma, but after just stopping the treatment, the child comes with recurrent episodes of wheezing. The child have been given OCS, then upgraded to long-acting beta-2 with not responding just after
How old? How old was
comes.
that? How old?
4 years old, sir.
4 years old.
4 years old child.
Usually PCD
And the child is not having.
Yeah.
So, though the child, the typical PCD is what we generally see is a Cartagena type of variety, where you have a dextrocardia and ear discharges, which the child didn't have, and the child is a term baby, not required any NICU stay, and there is no RDS. So, when you have a term, if you see a score called Picadar score, which says that there are certain criteria for Picadar score, where the child should have a term, respiratory distress, and there is no obvious cause for that respiratory.
Ear symptoms. Hello.
We have lost him.
Yeah. Is electricity problem?
I think some network issue.
Okay. Okay. So protracted bacterial bronchitis is not very common in our country. It is very common. Shangyuk, they must have got some cases there in.
No, sir. It is. Don't think it is uncommon, sir. In South India too, I have now 6 cases with me. It is not that we are.
What happened to you? Electricity gone or what? Or network?
Network. He's gone and he's coming and going.
Yeah.
Just like wheeze, he's coming and
Electricity
going.
gone, sir. We are.
Okay. Carry on, Pawan. Carry on.
So I had a patient who had come with 2 months old, failure to thrive, having delayed passage of meconium when we asked, but the mother, it is an infertility conception. We don't know whether it's a donor egg or a donor sperm. They said it is their own thing. And the child had failure to thrive, having recurrent cough since beginning, because the child was also having inspiratory, there is a stridor, subcostal intercostal retractions.
2 months, only 2 months old.
2 months old. 2 months old. 2 months old. I had to do a bronchoscopy. The child had laryngotrachea bronchomalacia with a thick greenish mucus, mucky-like sputum in the bronchi. I had to suck it out, very difficult. Sent for culture, grown Pseudomonas. So done a CFTR gene, which was positive.
Oh.
So we are seeing. So there is nothing called we are not seeing, sir. Only thing we need to have, if the child is not responding, because there was a child who has been diagnosed at the younger age group and doing well with only the physiotherapy, and the only thing is the airway clearance technique. So cystic fibrosis is a whole lot of things, but we need to have a clinical index of suspicion for cystic fibrosis and PCD.
Okay. Thank you, Pawan, for your input.
Welcome.
So we have what all these things are happening. So we had cases like bronchiolitis, low probability of asthma, high probability of asthma, and ultimately. Mamlik sir, please.
Doctor,
illegal ছিল না
So that so the atypical wheezers are the persistent, if there is persistent symptoms, neonatal onset, failure to thrive, choking and regurgitation, bacterial infection, clubbing, localized sign. Okay, so asthma is unlikely if there is a neonatal onset less than 6 months of age, localizing on unilateral signs, weight, productive cough, fever and poor weight gain, clubbing, poor response to bronchodilators.
Just like Dr. Pawan's case, as he was
Yeah.
saying, the one with cystic fibrosis.
Now, So now treatment, recurrent wheeze with viral EQI, no interval symptoms, no family history of asthma or any allergy markers, low probability of asthma, no controllers, only inhaled salbutamol. If the wheezing episodes becomes frequent or severe enough to require hospitalization, a trial of controller can be started. LTRA is an inferior option. In one go, this is the treatment. First, you have to rule out atypical wheezing, then find out whether it is infrequent, then go for only SABA. If it is frequent, you can have a trial of ICS, then stop it after 6 weeks. If there is no benefit, then revisit your case. If there is a good response, you stop it. If it recurs, then you again start and do the long-term therapy like asthma. Now, this is the last case. Sheikh Rahat Ali, 5-month-old, came to the clinic with a history of wheezing sound heard from the baby's chest. She gives a history of getting this wheezing sound for last 4 months since the child was admitted at 1 month of age due to query pneumonia. She couldn't tell it. Mother says she could hear the wheezing sound while the child is awake, playing, feeding, and it is absent when the child is sleeping. Occasional cough is present but not significant. Weight 5 kg, afebrile, respiratory rate 40 per minute, no feeding difficulty, no family history of asthma or atopy. Any of the panelists, what can it be?
So what was his birth weight? Like he's only 5 kgs at 5 months. So what was his birth weight and why like he was at
2.8 as far as I can remember, 2.8 or something like that.
so he has not actually grown well the
Yeah.
last 5 months.
Yeah.
And more of a laryngomalacia kind of a picture, but failure to thrive also because it is absent when the child is sleeping.
Yeah, I will show you the video.
Is he having lots of regurgitation of milk?
No, he's feeding well.
Does he have wheeze or just tachypnea?
Now you can see, you can hear the sound, no?
No,
You
couldn't hear
hear
this.
it?
Sir,
This is when, sorry?
Can you please play once again, sir? Because it was
Yes,
not that clear,
please.
audible.
Play once again.
Can you hear the sound?
A bit, sir, definitely.
Yeah.
Is it a unilateral or a bilateral wheeze?
Madam, you cannot see this is a sound where it's like stridor sound, like a biphasic
Yes,
stridor.
Yeah.
it's more like upper airway sound.
More, yeah. So more of a because it's absent when he's sleeping. So that's a clue for a malacia
This
only.
is when the baby is sleeping. No sound, absolutely
sound,
no dyspnea, no
Yeah.
tachypnea, nothing.
So it may be laryngomalacia, sir.
It
Laryngomalacia.
can be.
laryngomalacia would be a bit louder, madam. It won't be like this.
Yeah.
And
And laryngomalacia does not completely disappear in sleep. That's the
correct,
thing.
correct. The second
So
issue is that
laryngomalacia persists in sleep.
so my 2-3 questions which I would like to ask sir are, sir, there is something like urticaria on the child which I could.
Repeat your question. Couldn't hear it.
Urticaria. He's asking about the urticaria on the abdomen.
No urticaria.
Because
There
that
are
was
some
looking like
seborrheic dermatitis are there, but no urticaria.
because that picture was looking. Was there anything like at the neck behind, sir? Any hemangiomas like picture?
No.
Okay.
So some cystic hygroma.
This is the X-ray. This was done at 1 month of age when the baby was admitted, and this is
So the
what
possibilities, because one you would hear a laryngeal web.
maybe, I don't know.
Thymus has increased.
Sorry. What I did the car. What I did, actually, I tried a short-acting beta-2 agonist without knowing anything. I must admit, for 10-15 days.
Thymus, madam is saying thymus.
That was
I had subglottic hemangioma.
no. That is at 1 month of age. Thymus. This is 5 months. This is the X-ray what I did. And
Hyperinflation.
this is at 9 months of age when the child came to me. Sorry. This is at 9 months of age. 8.5 months of age. So what it can be? Tracheomalacia?
Which has improved with age.
Sorry?
Has it improved with age? Because he seems to be growing well now.
Yes. He is growing well, no sound as such. I think it was a tracheomalacia, something like that, as the child was having so much of wheeze.
Yeah, probably because otherwise it would not go away with age.
Yeah. By 2 years of age, it goes out. No?
Mm-hmm.
Anything? Over? Yes. Your input. Okay. If nothing is there, then we should stop here. Thank you very much. Thanks.
Thank you
I
very
would
much.
definitely say this would be.
Sorry.
Yes, Dr. Pawan.
I think there's a lot of problem on his end.
Network issue maybe.
I think Shantanu, you have highlighted the most important points in wheezing and the importance to rule out the asthma mimics. That is so very important as learning points for all of us. Like we are sometimes in a busy clinic, we stop thinking and we don't think of those mimicking situations. And I think that is a very important thing, thinking of congenital heart disease, thinking of the malicious, thinking of foreign body, and also thinking of mediastinal mass. These 4 things are so important, and you highlighted that so beautifully. I think these are the most important take-home messages from this evening's talk. I don't know whether the others will agree.
Thank you very much.
Yeah, sure. And the probability of asthma, which is like always a question with the mothers.
The way it was,
Yeah, so they come and first thing they want themselves is their child to get nebulized. So they will come and ask, so first they'll ask for a clinic nebulization and then they'll ask whether they can continue the same at home. So very difficult to convince them about the inhaled corticosteroids. So, and
they come to you very often with the nebulization from the coax.
Yeah. So to convince them about, and the probability of asthma charts would be very helpful. So we can give them some like proper, these are the points which may happen, may not happen. So, and it is always a follow-up which is important because it may change. The course of the disease may change.
It's very important, and it's good that if the patient continues to come to you for follow-up, that is also very important. Because the patient I talked about having a mediastinal mass, lipoblastoma. It was finally. This child had seen every pediatrician. They have hopped around from one person to another. Now, all the time, and the first go it doesn't strike you. It's when then the second go that the patient comes and not responsive to ICS, or the child is not growing, or there is a localizing, then it comes to you. But this is also a problem with our patients here. They tend to change doctors sometimes so frequently. So by the time the patient has come to me, they have seen 5 or 6 different doctors, and
Yes.
each time only one single visit. I was lucky because I saw everybody's prescription and then I thought of something else. But every time in a busy clinic, it's not possible always to hit on it for the first time.
Okay, thank you, Pawan. Thank you, Sanjukta. Thank you, Amita. And over to you, Devjani, if you are there.
Thank you, sir. Thank you.
Thank you so much, Shantanu.
Thank you, Shantanu.
Thanks. Thank you all.
And thank you to so many senior doctors who have attended today. Dr. Mangulik, Dr. Gautam, and others.
Shubhashri shall come, I think. Shubhashri